Welcome back to the Deep Dive. Today we are taking a plunge into one of the most fundamental areas of neurological stability,
Yeah.
how we use anti-seizure medications or ASMs to decode and, well, tame the brain's electrical systems.
It's a fascinating area, and the scale of the challenge is just massive. Epilepsy, which is defined by recurrent seizures, is the fourth most common neurological disorder in the world.
Wow.
Yeah, you're talking about approximately 1% of the entire world's population managing a chronic brain disorder. You start to realize just how critical these pharmacological tools really are.
Absolutely. So let's start at the very beginning with the event itself. For anyone listening, what is the clearest physiological definition of a seizure? What is that abnormal event?
A seizure is essentially a brief, transitory alteration in consciousness, sensation, or behavior. On a cellular level, it's caused by an abnormal, highly synchronized, and frankly excessive electrical discharge.
So like a power surge.
Exactly. Think of brain networks just starting to fire in these rapid, high-frequency bursts all at once, totally overwhelming the normal checks and balances. And the specific symptoms you observe, whether it's, motor activity or a sudden blank stare, that depends entirely on where in the brain that storm starts and how far it spreads.
Okay, that synchronization, that sounds like the core of the problem.
Mm.
So let's unpack the spectrum of epilepsy. How do we categorize the roots of this condition, the etiology?
Well, etiology is traditionally broken down into two big camps. First, you have what we call symptomatic epilepsies.
Meaning there's a clear cause.
Right. It means the condition results from some kind of acquired structural damage, say a stroke, a traumatic brain injury, an infection, maybe a brain tumor.
And the other camp?
Then we have the genetic or idiopathic causes. And these can range from really complex polygenic inheritance all the way down to specific single gene defects.
And it's those single gene defects that often lead to the most challenging conditions, right?
Precisely. They're often classified as developmental and epileptic encephalopathies, or DEEs. This is where the condition doesn't just cause seizures, it actively impairs neurodevelopment.
What are some examples of that?
The most severe would be conditions like Lennox-Gastaut syndrome and Dravet syndrome. Dravet is frequently linked to mutations in the SCN1A gene, which codes for a really crucial component of a voltage-gated sodium channel.
That sets the scene. Now, moving from the cause to the clinical presentation, how do clinicians actually classify the seizures themselves? I know the terminology has been updated, but the clinical difference is really what dictates the treatment path.
Correct. The modern classification really centers on where the seizure starts. So you have focal onset and generalized onset.
Focal meaning local.
Exactly. It starts locally in one hemisphere. If the patient stays fully aware, it's a focal aware seizure that used to be called simple partial. If awareness is impaired, it's focal impaired awareness, or the old complex partial. And, critically, that focal seizure can then spread. It can become a focal to bilateral tonic-clonic seizure.
That's the one everyone recognizes, the grand mal.
Indeed. But generalized onset seizures are different. They involve both hemispheres from the very beginning. The generalized tonic-clonic is the classic stiffening, the tonic phase, followed by jerking, the clonic phase, and loss of consciousness. Usually under 3 minutes, followed by what we call a postictal period of confusion or fatigue.
And what about the ones that are often missed, especially in kids?
Those are the generalized absent seizures, the old petit mal. They are incredibly brief, sometimes under 10 seconds. It's just a sudden lapse of consciousness or attention. The child usually just resumes their activity right afterward, no confusion at all.
Wow. And then you have the more severe types.
Yes, then you have atonic seizures, the so-called drop attacks, which are a sudden loss of all muscle tone. You see these commonly in severe DEEs like Lennox-Gastaut. Getting this diagnosis right is just essential.
Why is that?
Because treating a focal seizure with the wrong drug can actually worsen a generalized seizure and vice versa.
That brings us right to the ASMs, the pharmacological toolkit. So these drugs are preventive, right? They're used chronically to stabilize the brain, not just as rescue medicine.
Exactly. They act like stabilizers. They suppress that tendency of neurons to fire in that high-frequency, synchronized way. And they do this by hitting one of 3 primary molecular targets that govern how excitable a neuron is.
Okay, let's start with the one that seems to target that high-frequency burst most directly, the sodium channels.
That's the voltage-gated sodium channel blockade. It's the mechanism for a lot of first-line drugs like carbamazepine, phenytoin, and lamotrigine.
So how does it work?
When a neuron fires rapidly, its sodium channels cycle through resting, open, and then inactivated states. These ASMs, they bind preferentially to the sodium channels when they're in that inactivated state. They basically lock them there, stabilize them, and prevent them from rapidly reopening.
So it's a clever mechanism. It's what they call use-dependent. How does that actually, how does that ensure it targets the epileptic neurons and leaves the normal ones alone?
Because the block accumulates during high-frequency firing. If a neuron is going wild, say, 100 times per second, it spends much more time in that inactivated state where the drug can latch on.
Ah, I see.
A normally firing neuron just doesn't offer that window, so the drug preferentially shuts down the epileptic circuit. Carbamazepine is a classic prototype here, used for focal seizures and even other things like trigeminal neuralgia.
Okay, but we talked about Dravet syndrome earlier, linked to that SCN1A sodium channel gene. So if sodium channel blockers are so effective, do they help in a syndrome like Dravet?
This is one of the most critical and counterintuitive safety insights in this field. No.
No.
Sodium channel blockers, like carbamazepine or phenytoin, are often contraindicated in SCN1A-related Dravet syndrome.
Wait, that seems backwards.
It does, but the mutation often causes a loss of function in critical inhibitory interneurons. So if you then block the already weakened sodium channels with a drug, you disrupt the balance even further. You can actually worsen the seizures or even cause status epilepticus.
That's a fundamental distinction.
Yeah.
It shows you can't just suppress a symptom. You have to know the underlying molecular problem.
Exactly. It's the shift to precision medicine.
Okay, so moving to the second main mechanism, how do we use the brain's own brakes?
We enhance GABA, gamma-aminobutyric acid. It's the brain's primary inhibitory neurotransmitter. The goal here is to hyperpolarize the neuron, make the inside of the cell more negative, which makes it much, much harder to reach its firing threshold.
And what are the different ways we can boost GABA?
Well, the most common acute examples are benzodiazepines, like lorazepam. They act as positive allosteric modulators on GABA receptors. They basically just open the gate wider for chloride ions to rush in and hyperpolarize the cell.
Okay. Any other approaches?
Another fascinating one is vigabatrin. It works by irreversibly inhibiting an enzyme called GABA transaminase.
And what does that enzyme do?
It's the enzyme responsible for breaking GABA down. So if you stop the breakdown, the concentration of GABA in the synapse goes up.
Clever. And finally, the third mechanism. This one seems uniquely tailored for those brief childhood seizures, the absence episodes.
That's the T-type calcium channel blockade. These channels are found mostly in the thalamocortical neurons, and they are the key player in generating those very specific oscillatory spike wave discharges you see in absent seizures.
It's a feedback loop, right, between the thalamus and the cortex.
It is. And ethosuximide is the prototype drug here because it's highly selective. It just stops that specific oscillatory circuit, often with very little effect on other seizure types.
Understanding the target is crucial, but treatment so often comes down to pharmacokinetics, how the body handles the drug. And few drugs in medicine are quirkier than phenytoin.
Oh, phenytoin is infamous among prescribers. Its elimination follows what we call saturation kinetics, or nonlinear kinetics. For most drugs, if you double the dose, you double the blood concentration. That's linear.
But not for phenytoin.
Not at all. Its metabolizing enzymes in the liver get saturated right within the therapeutic dose range.
So what does this actually mean for the patient and the doctor in the clinic? You can't just follow a standard titration schedule, can you?
Exactly. It means that once the patient gets into that therapeutic window, even a small, seemingly insignificant dose increase can just overwhelm the liver's capacity to break it down.
So the concentration shoots up.
It shoots up sharply. You get these disproportionately high serum levels and rapid toxicity. You'll see symptoms like ataxia or dizziness very, very quickly. It demands frequent blood monitoring and extremely cautious dosing.
And carbamazepine has its own puzzle, right? Autoinduction.
It does. Carbamazepine is mainly metabolized by the liver's CYP3A4 enzyme system, which is, a superhighway for drug metabolism. But carbamazepine has this peculiar ability to induce its own metabolism.
It speeds up its own breakdown.
Yes. When a patient starts therapy, the half-life is around 36 hours. But over the first few weeks, the drug stimulates the production of those enzymes, causing its own half-life to drop to just 8 to 12 hours.
So you have to increase the dose later on just to stay at the same level.
You do. You have to adjust the dose a few weeks in just to maintain what was initially an effective concentration.
Let's pivot to some of the newer agents. Levetiracetam, or Keppra, is incredibly popular. It has predictable linear kinetics, but its mechanism is totally different from the classics.
Levetiracetam works by binding selectively to a protein called SV2A. This protein is found on synaptic vesicles, the little packets that store neurotransmitters.
So what does SV2A do?
It plays a role in the precise release of neurotransmitters. By binding to it, levetiracetam seems to dampen the excessive dumping of excitatory neurotransmitters like glutamate during an epileptic episode.
So it's not blocking the channels directly, it's regulating the supply of the excitatory chemical.
That's a perfect way to put it. It regulates the supply chain. But as effective as it is, we have to mention its distinct safety profile.
The behavioral side effects.
Yes. It has a known propensity to cause behavioral and mood changes, often described as irritability, anxiety, aggression, or in rare cases, even acute psychosis.
That must be incredibly challenging for families. You're trading seizure control for potentially severe psychological side effects.
It creates very, very difficult clinical decisions. It's a constant balancing act.
And moving to other novel treatments, cannabidiol, or CBD, has gained approval for those highly refractory syndromes, like Dravet and Lennox-Gastaut. What's the key pharmacokinetic hurdle doctors have to solve with CBD?
Its oral bioavailability is low, typically below 20%. CBD is highly lipophilic, it loves fat, and it gets extensively metabolized by the liver on its first pass.
So how do you get around that?
To overcome this, it has to be formulated in an oil-based solution, like sesame oil, or you take it with a high-fat meal. The oil helps create these little micelles that allow the drug to bypass that initial liver metabolism.
And that actually increases its absorption.
Significantly, sometimes 4 or 5-fold.
That's a massive jump, making the difference between an effective treatment and an ineffective one based on what you ate.
It dictates the entire dosing schedule and ensures you get consistent exposure. And, while we're on novel approaches, we should highlight a non-pharmacological one, the ketogenic diet.
High fat, very low carb.
Right. And while it's often used as an add-on, it is the recommended first-line treatment for a very specific metabolic disorder called GLUT1 deficiency syndrome.
A diet as the first line of treatment. That really underscores how specific these etiologies can be. Let's shift now to the acute emergency. Status epilepticus. What is the modern definition of this state?
Status epilepticus, or SE, is a medical emergency where time is brain. The operational definition now is continuous generalized tonic-clonic seizure activity lasting 5 minutes or longer.
5 minutes, not 30.
Right. For non-convulsive seizures, the threshold is typically 10 minutes. Waiting for the old 30-minute benchmark is simply too late.
And the immediate first-line response is almost always a benzodiazepine. Why is lorazepam often the preferred choice intravenously in the hospital over, say, diazepam?
It really comes down to pharmacokinetics and lipid solubility. Diazepam is highly lipophilic. It gets into the brain very fast, but it also redistributes out of the brain and into peripheral fatty tissues very fast.
So it's fast on, fast off.
Exactly. Its effective duration might be less than 20 minutes. Lorazepam is less lipophilic. It still gets into the brain quickly enough to stop the seizure, but it doesn't redistribute as fast.
So it sticks around longer.
It does. This gives lorazepam a much longer, more reliable clinical duration of action, typically 4 to 12 hours.
That small difference in fat solubility dictates the whole treatment protocol. And for out-of-hospital scenarios like acute repetitive seizures, where a patient recovers between clusters, what are the options there?
For those seizure clusters, we use non-injectable benzodiazepines, things like midazolam nasal spray or diazepam rectal gel.
Yeah.
It's an important logistical point, though, that rectal administration, while it's effective, carries a pretty significant social stigma and practical difficulties, especially for adults in public. This is what's driving the push toward nasal or buccal routes.
Finally, we have to address the critical safety profile around pregnancy. What do we need to know about the teratogenicity of ASMs?
This is paramount. And no ASM is considered entirely risk-free for a developing fetus. The one that carries the highest, most well-documented risk is valproate.
And what's the risk?
Exposure during the first trimester significantly increases the risk of major congenital malformations, most notably neural tube defects like spina bifida. The absolute risk is in the 6 to 9% range.
That is a life-altering risk profile. When managing epilepsy in women of childbearing potential, that has to be one of the hardest conversations a clinician can have.
It's an ethical and clinical challenge that you can't overstate it. We also know phenobarbital carries an elevated risk, often linked to cardiac defects, and topiramate is associated with an increased risk of oral clefts.
So those three are avoided if possible.
If at all possible, yes. Valproate, phenobarbital, and topiramate are avoided completely in this population as the risks, especially for valproate, are dose-dependent.
And beyond teratogenicity, let's just briefly touch on a couple of long-term adverse effects that really impact quality of life.
Sure. Phenytoin, which was a workhorse for decades, can cause long-term cosmetic effects like gingival hyperplasia, that's an overgrowth of gum tissue, and hirsutism. And then there's vigabatrin, which is used for infantile spasms. It carries a black box warning for irreversible retinal dysfunction.
Irreversible.
Yes. It can lead to permanent bilateral concentric visual field constriction and vision loss.
Irreversible vision loss. That must mean intense, lifelong monitoring.
It does. It just illustrates the trade-off we so often have to make between controlling a severe disease and dealing with serious, permanent side effects.
This has been a deeply insightful look into the pharmacological battle against neuronal hyperexcitability. We've mapped out the key strategies: blocking sodium channels, boosting the GABA brakes, and targeting those specific T-type calcium channels.
And we saw how important the pharmacokinetics are, from phenytoin's saturation kinetics all the way to CBD's need for oil.
And we saw why a precise molecular diagnosis is just mandatory, given the danger of using a standard sodium channel blocker in a genetically defined syndrome like Dravet.
Right.
So let's leave you with a final thought on where this field is heading. Historically, ASMs were discovered almost accidentally through really simple animal screening tests, like the maximum electroshock test. And those tests, they mainly identified broad neurological suppressants, which happen to be great sodium channel blockers.
But today, we're identifying the exact molecular fault glitch in a potassium channel or a faulty signaling pathway like mTOR in tuberous sclerosis.
So the question is,
The central question for the future of treatment is this: how radically will drug discovery shift away from developing these broad neurological suppressants towards highly targeted personalized therapies? We're already seeing treatments in development, things like specific potassium channel openers or highly targeted gene therapies designed to fix that single molecular mistake. Will the era of broad-spectrum ASMs be completely replaced by precision epileptology?
a fascinating path forward for neuroscience and medicine. Thank you for guiding us through this really complex material.
My pleasure.
And thank you for joining us for the deep dive. We'll catch you next time.